Kind words, and I know it's post-lunch session, not a very good time to talk and make presentations, but I will try my best to keep you all awake by keeping it short and swift. Okay, so in my presentation in the next 20 minutes, I'm going to talk about what is universal health coverage, how have some countries achieved it, and maybe I'm being very presumptuous by saying maybe what first steps that India can take to achieve universal health coverage. For people, older people like us, you all may have heard this song. For the youngsters, I would request you all to Google it on YouTube and you will get it. This was, sung by a very famous Beatles, from the Beatles band, John Lennon. Now, what I am trying to say is trying to think of, imagine, So imagine, that's what I want you all to get into in that frame of mind. And then I'll take you through 3 or 4 case studies. Imagine that a laborer walks into a health facility with fever, gets clinically examined, diagnosed, and treated, all without having to pay any money. You'll say, yeah, what's so new? That's what our primary health centers do. Or imagine your domestic maid who comes and works every day in your house. She goes in the evening to a clinic and gets her diabetic medicines, again without having to pay any money. Yes? A little different from the first case study. Imagine an Adivasi with multiple fractures. He was collecting honey and he fell down from the tree. He's referred to a district hospital for treatment and receives full treatment. After over 2 months, all his bones are set in place. His pelvis is, the wounds on the fracture in the pelvis is healed. And he's able to walk back home, but again, not having to pay any money. Again, imagine a carpenter who's doing some work on your furniture. He suddenly develops some chest pain. He's transferred to a nearby hospital. Physician does an ECG, says, yes, this is acute MI, admits him in the ICU and treats him and sends him back home after 10 days. Imagine a 40-year-old executive, an IT professional, who's diagnosed to have breast cancer and gets the correct treatment, again without having to pay any money at the point of care. So the common thread in all this is that one is there's no financial hardship, that nobody has to pay at the point of care. I'm not saying that nobody has to pay, but I'm saying nobody has to pay at the point of care. When they are suffering from the illness, they do not have to worry about making payment. And it is not just the poor we are talking about. We are talking about ranging from the Adivasis all the way to an IT professional. And we are not just talking about reproductive and child health. We are talking of the entire gamut of health problems that a human being can face. And that is, ladies and gentlemen, what is called universal health coverage. All individuals, and this is not what I'm saying, this is what WHO has defined it, all individuals and communities receive quality health services. In the earlier definition, quality was not there, but subsequently the word quality was introduced because it's not enough to have health services, but it needs to be of good quality without suffering financial hardship. So this is not a new definition. If you look at historically, this is what has evolved from way back from 1946 when WHO was formed. That time also they said we should make sure that people attain the highest level of health, and then Alma-Ata, and now UHC. It's the same thread which is going along, that everybody, not just the poor, but everybody receives the quality healthcare services that they need without suffering financial hardship. That financial hardship was not there in the Alma-Ata Declaration, so that is a new addition under UHC. Now, you may say, oh, this is great, this is imagination, but does it work? Yeah, it may work in UK, it may work in Australia, Canada, but what about other countries? It works in many other countries, many middle-income countries, some even low-income countries. Our very close neighbor, Sri Lanka. In fact, I think we are quite close to Sri Lanka. They are nearly there in terms of universal health coverage. A small country with not very high GDP, lot of conflict, but still they managed to move very close to universal health coverage. Now, when I say this, most people tell me, oh, but Sri Lanka is a small country. You know, India is a huge country. And I try and remind them, in India, health is a state subject. And Sri Lanka is like one of our states. How is it that our states have not yet reached, none of our states have reached universal health coverage? So we can't keep on hiding behind the fact that India is a 1.3 billion populated huge country. No. Look at it in terms of states and see where are we in terms of universal health coverage. Of course, the most famous example is of Thailand. Everybody talks of Thailand, but there are many others. Cuba did it much before Thailand. Morocco, Colombia. Yeah. So this is a map which shows which are the countries which are achieved or achieving universal health coverage. All the green color countries, the countries colored green are the ones which are nearly there or already have achieved it. Then the blues are somewhere in the middle and the red are way back, way down. And you see some of the red, these things are sub-Saharan Africa, but we are nowhere there, we are in the blue. Now I will take you through this in a little more detail. So how did these people decide which country is nearly there or way behind? They estimated it using this famous cube. I don't know, I'm sure most of you all would have seen this at some point of your public health career, the UHC cube. Personally, I feel this is a very confusing diagram because it's a conceptual diagram which needs to look at things in 3 dimensions, and most of us are used to looking at photographs and images in 2 dimensions. But basically, what are we talking about? We are looking at the depth of the cube, which are the services which are covered, who is the population who can access these services, and can they access these services with minimal hardship, financial hardship at the point of care. And the orange cube, it's orange here, orange cube is what your current position is, and then you're supposed to be expanding that orange cube so that it covers the larger cube. So that is the goal of this diagram. But like I said, it's quite complex. So let me take each one of these dimensions in a little step by step and explain to you what exactly goes into these into this cube. So like I said, service coverage, population coverage, and financial coverage. So service coverage, people talk of many things. I'm trying to simplify it. I'm saying ambulatory care, which means outpatient care for anything. It may be for antenatal checkup, it may be for your vaccination, but it'll also be for your chronic back pain. That is what ambulatory care is about, not just a few disease conditions. In fact, there was a study done by ICMR in Orissa, and they showed that more than 30% of people who come to the outpatient are not pregnant women or children. They are elderly meaning 50 plus age group who are got chronic myalgia. Now, if you can't treat those patients and you say, no, sorry, I'm here only to treat, to provide antenatal, maternal and child health, they don't come back to you after that. They go to a private sector or go to a quack or don't take any treatment, and they continue to suffer. So in our move towards universal health coverage, one of the essentials is to cover a comprehensive ambulatory care. Inpatient care, again, I'm not saying only for certain diseases like many health insurance schemes have done, only for cardiac cancer. I'm saying inpatient care, ideally secondary and tertiary. But if not, that is not possible, then you have to decide which one, depending on your context. If your government health services are very strong and are providing good quality secondary care, then you may want to cover only tertiary care. On the other hand, if you've got good quality tertiary care, but your secondary care is not working, then you provide secondary care. But don't decide blanketly just because somebody in Delhi tells you. Look at what your context is and decide that. One of the things which is often neglected is emergency services. Most of our PHCs close down after 4 p.m. in the best case scenario. But what happens after that? 5 p.m. if somebody has a fall and fractured his leg, forget a fracture, I can understand, has to go, but has got a tear a small cut in the leg, you have to go to the hospital because there's no PHC, primary health center, available to just clean and dress the wound. Dental services is often neglected. Screening, this thing. And then, of course, you have your preventive and promotive services, which is your nutrition, tobacco control, lifestyle changes, safe drinking water, sanitation, etc. Now, all of this ideally should be provided under service coverage. Now, WHO realized that, yes, what we are saying is very good, but we do not have indicators to measure many of these disease conditions. So they came up with a very limited definition of service coverage, and which they measure, which is RMNCH, infectious diseases, non-communicable diseases, and service capacity. And then they made a composite index for all the countries, depending on the performance on these indicators, very limited indicators, I must say. And the darker shaded countries are those who have providing most of the services. The orange are providing about 60 to 70% of the services, and you have the lighter shaded ones like India, which is providing just about 50% of the services that is required under the WHO definition of service coverage. So this is in terms of service coverage. If you see, we are closer to sub-Saharan Africa in terms of service coverage compared to most other countries. When it comes to financial coverage, everybody today talks about the fact that out-of-pocket expenses is not acceptable, and it causes catastrophic health expenditure, it causes people to get impoverished, and so we must reduce it, especially at the point of care. So here, this is a measure again used by WHO, looking at families which have spent more than 10% of their annual income on medical related expenses. And you see India, all the light colored countries are countries where the populations or the patients spend very less amount. India, of course, is on the top bracket. We have one of the highest index in terms of catastrophic health expenditure due to out-of-pocket payments. So this is, again, we are not doing too well on the financial coverage. When it comes to population coverage, we usually talk of population groups like mothers, children, but we rarely go into further depth of which mothers. Is it the mothers who live around the PHCs or the district hospitals? What about those mothers who are living on the hills? What about those people living in the slums who have to go to work from 8 o'clock or 7 o'clock till 6 o'clock in the evening, and when they come back, the PHC, of course, is not available for provide their services. So we try and look at, I've just given a list, but there are many more things. Somebody would want to say, what about the transgenders? What about the minority religious groups, etc.? So, but when we look at, when we do our studies and when we think, we need to look at these population groups. I mean, look at not just a homogeneous population, but divided by different population groups. So this is a very, very rough and crude estimate of universal health coverage in India. I used the service coverage, the same which WHO has said, given an index of 55 out of 100. Population coverage, because WHO, surprisingly, I couldn't find that index on population coverage. I just took I just took one indicator from the NFHS, which was the proportion of pregnant women who delivered in institutions in the poorest quintile. And we have, it's about 60% only, rest 40% don't deliver in institutions, they deliver either at home or along the way, etc. And then financial coverage. Again, financial coverage is misleading because that is about 17% have catastrophic health expenditure. So I have just reversed it, saying those who do not have catastrophic health expenditure, which is 83%. Like I said, these are very crude, but it's just to give you an idea that we still have a long way to go. Most countries have to work only on service coverage or population coverage, but we have to work on all the three dimensions. Still with me? Nobody's sleeping yet? Okay. I will take you quickly through a couple of examples, country examples. Like I said, Thailand is the most famous, so I will talk about Thailand. Thailand had a similar fragmented health system like India. This was in 1999. We had multiple groups, like the civil servants had very good health coverage, like our CGHS. Then the employees in the factories were covered like our ESIS. But in India, ESIS is only covered up to 21,000 wages. There, anybody who worked in the formal sector was covered by a scheme similar to the ESIS. And then, of course, there was private health insurance. There was some coverage for the poor, and the middle were totally left to their own resort to where there was a lot of out-of-pocket expenditure. There was a growing private sector, etc. At that time, there was an election happening in 2000, and Thaksin, he was the prime ministerial candidate. He made one promise. He said if you vote for me, he's a new person in politics, very new. He's never been a MP or anything in Thailand politics, very new, first time. He said, if you vote for me, I will ensure you all will get free health care. He won the elections. 2000, when he joined, he said, give me solutions on how to do free health care. Luckily for him, there was a very strong research community in Thailand which had done a lot of background work on out-of-pocket expenditures, on service coverage, etc. And they came up with solutions. And one of the solutions which Thaksin liked was give everything to everybody free of cost. You have to only pay 30 baht, which is equivalent to about 20 rupees. So you pay 20 rupees for whether you go to the hospital or to the primary health center, you pay 20 rupees and you get free treatment. From the primary healthcare center till the tertiary hospital. Now you'll say, oh, that was possible because Thailand is a rich country. But actually in 2000, Thailand was just recovering from the Asian economic crisis. So they were not a rich country at that time. Their GDP was quite low. It was some $2,000 per capita at that time. One of the lowest it ever was. But still, Thaksin said, I don't care, I had made this promise, and for me the health of the people is more important than anything else. So he allocated money for health, and what do you see? I'm just taking one indicator, outpatient user rate from 2.4, it has gone up to 3.6, nearly 50% more. That means more people are accessing the outpatient for their needs. Catastrophic health expenditure, which was in 2000 about 5.7, has come down to about 3.1%. Remember, ours is about 17%. So just this sort of intervention it was a big bang approach, and today all Thais get free health care at the point of care. They have to pay that 30 baht still, but they get quality health care services. Their health indicators are on par with most high-income countries. So this is one model of achieving universal health coverage. Another model was Turkey. Remember, Turkey is a European country. So in 2002, it had also a lot of fragmented health insurance schemes for the civil servants, for the employed formal sector, nothing for the poor, etc. No, and most important, their systems were not working. Their primary healthcare centers, their hospitals, etc. were not working. It's again something similar to what is in our situation today. So the new Prime Minister who took over, what he did was he integrated all the health insurance into one single health insurance. He said, rubbish. Everybody should be covered under one health insurance. He said it's mandatory. Very, very radical, because normally health insurance is usually voluntary. I choose this thing. But he said, no, everybody will be covered under health insurance. The poor will be subsidized by the government. All the others have to pay and purchase health insurance. They have to pay their premium and purchase. And for this, he changed the laws. He made health insurance mandatory. One very good thing he did was, he said, our government health systems are not working because most of the doctors from 9 to 5 doing nothing, and then they go to their private clinics and practice there and divert all the patients there, and so patients are getting this thing. He said private practice is banned. Now all the doctors went up in arms. But he said, if you don't work, I will import doctors from outside the country, and I will make sure our Turkish health system works. all the doctors went back to the primary health centers and the hospitals and started working. And he focused, today you look at most of our health ministers or our health speeches, it is always on, we have given so many primary health centers, we have constructed so many health and wellness centers. It is always the focus is on inputs. But there he focused on the outcomes. He said, I want these to be achieved over the next few years. IMR reduced. As you know, most of you all are epidemiologists here, as you reach the peak of your target, the achievements plateau and the marginal gains are much less. But Turkey was able to reduce in just 10 years' time the IMR from 31 to 8. Catastrophic health expenditure also reduced. I will just take two more examples. Burundi is one of the poorest countries in the world. So you don't think that universal health coverage is only for high-income countries. In 2005, when a new president came, he realized that the health indicators in Burundi were one of the worst in the world. IMR and MMR was very high. And one of the reasons was because people had to pay out of pocket for, even in government health services, for vaccines, etc. So he said everything, maternal and child health will be free at the point of care. That's all he said. Only one thing. And he managed to convince the World Bank and the UNICEFs and all to donate to that initiative. And IMR and MMR in just 5 years' time, 2005 to 2010, dropped by 43%, one of the fastest declines any country has ever achieved. Of course, unfortunately, it has stopped at MCH, has not gone beyond that. But I'm just trying to say, because we did the same thing in 2005. We also introduced JSY, we introduced institutional deliveries, etc. Our institutional deliveries went up, but our MMR and IMR did not go down as fast as we hoped for. South Korea. Again, they introduced a national health insurance, progressively covered all the population. Important that they put in laws to regulate the private sector, both the insurance companies as well as the providers. They said, insurance companies, you cannot charge a premium more than this. This is the standard premium for all the families across the country. It's not markets anymore. To the government, to the hospitals and the private practitioners, they said, you can only charge this much. If you charge more than that, the government will penalize you. So these were the kind of laws that they introduced. He realized that the government realized that they don't have enough doctors, so primary health care by nurse practitioners. So this has been the path, few examples. So how do we reach from a very low, small cube to a large and expanded universal health coverage cube? There are many ways. We can do it through health insurance, like some countries have done it. We can do it through government taxes. I think the debate of whether it should be only tax-based or only insurance-based, those days are gone. Today, people recognize that either way is okay as long as it is prepayment. People pay in advance, either through taxes or through insurance premiums, to reach so that they get covered. You can have a big bang like in Thailand, or you can have incremental like in Turkey and other countries. Most countries prefer the incremental route. But what is required is political will, strategic vision, legal reforms, and assured finances. I'm not saying a lot of finances. I'm saying assured finances. The government says, yes, I want to achieve universal health coverage, and I will put aside whatever money, this amount for this, and I will not touch it for the next 5 years. I will ensure that you all receive this money. Unfortunately, in our country, this is 2020, and in another 10 years, we are supposed to achieve the SDG goal of 3.1 of universal health coverage. And we are still talking of, we will provide primary health care for reproductive and maternal health, for some communicable and non-communicable diseases. We don't even talk about the population who we will cover, the vulnerable populations. We don't talk in our national health policy. Then we talk about assuring, reducing out-of-pocket expenditure. But what do we have? We have Ayushman Bharat with only 12 health and wellness centers with only 12 packages. We have a PMJ, which I'm currently living in Delhi and I happen to see the interactions. The PMJ people will not talk to the health and wellness center people. These are two different programs. How do you talk of universal health coverage if they don't talk to each other? Then you have your departments of primary health care centers, community health centers. I visited a few health and wellness centers and they told me, if we have to do this thing, we refer them outside. Where do you refer? To those PHC people, no? I said, those PHC people are your people. No. We are different. We are health and wellness center people. PHCs are different. So you see, our system is so fragmented that unless we get that strategic vision of bringing everything together, it's unlikely we are going to move even a step in the direction of universal health coverage. One thing I'm sorry to say is our lack of strategic vision. 10 years we have. We still don't have a document to say how are we going to achieve universal health coverage by 2030. Neither the political class, nor the bureaucratic class, nor us as technical researchers, the public health professionals, none of us are thinking in that direction. I would like to end with the last phrase of that song. I am nearly going out, one foot in the grave. So I hope, but I still dream of a day when India will achieve universal health coverage. But I hope that you will join me in that dream. And we will have truly universal health coverage for our citizens. Thank you very much.